Good evening, everyone. Thank you so much for joining us on this very important occasion where we're planning to discuss screening guidelines for colorectal cancer. We have a very important guest in our midst, who is also a member of society, but is here as a speaker, Professor Ray-Offor. He is a professor of minimal access surgery at the College of Health Sciences, University of Port Harcourt. He's also the head of colorectal and minimal access surgery unit at the same institution, and also holds another cap as the head of Department of Surgery. So we are very delighted to have him in our midst to talk about this very important topic. And I would just like to join us to reflect on this as he talks about it, hoping that we'll have a very robust engagement. As usual, there will be time for question and answer that will be moderated by our international rapporteur. And then you can always put in your questions and your comments in the chat function. And this meeting is being recorded as usual, and it will be posted in due course after appropriate editing. And without further ado, I'd like to hand over the platform to Professor Ray-Offor to continue the talk. Thank you.
Thank you very much, President. For the next 45 minutes thereabout, I'll be talking on screening guidelines for colorectal cancer. My name is Emeka Ray-Offor. All protocols duly observed. My screen is freezing. Sorry. Yeah, I have no disclosures at the moment. The learning objective for this presentation is one, to understand the need for screening for colorectal cancer. Another is to learn the risk stratification of patients for screening, and then to highlight the various modalities for screening for colorectal cancer. And lastly, and most importantly, to emphasize the role of screening colonoscopy. The burden of colorectal cancer is the second leading cause of death, and it's a worldwide disease pathology, more common in the Oceania, Western Europe, and Northern America. The trend of high incidence seems to have reduced a bit or stabled out with effective screening modalities, but there are climes where the incidence, once believed to be low, is now rising. One of that is in sub-Saharan Africa, where the trend is a median age of colorectal cancer in Nigeria being 53 years. Note that it's very relevant to our recommendations, but it's important to note that this disease is more in the Western population, is more with those in the seventh decade, that's in the 60s, that they have the median age. A little bit about the pathogenesis. About 95% of colorectal cancer arise from pre-existing dysplastic colorectal polyps, adenomas. There are multiple processes that have been hypothesized regarding the pathogenesis. One that is established is the adenoma carcinoma sequence, where there are multiple hits of mutations, the APC, KRAS, and so on. It's not like a mutation in one particular gene leads to the development, but multiple of that in sequential order eventually progress from the pre-malignant to the malignant. Another is a chromosomal instability, and then another is the epigenetic alterations like the BRAF mutation, the CIMP, and then microsatellite instability. And this mismatch repair deficiency leads to the Lynch syndrome, that's the hereditary non-polyposis colorectal cancer. There are syndromes that are associated with colorectal cancer, and this include the classical familial adenomatous polyposis, inherited as an autosomal dominant disorder, where the APC gene is involved, and there is a presence of over 100 polyps in this patients, and then there are associated features tumors of the CNS and musculoskeletal subcutaneous masses in the subcutaneous tissue and the likes. The attenuated type of familial adenomatous polyposis, in this there are fewer number of polyps, 10 to 50 polyps, unlike the classical. Then you have the MUTYH associated polyposis and rare genetic causes of multiple adenomatous polyposis, in which there are molecular there are mutations and molecular changes that have been studied and been identified. Other hereditary colorectal cancer syndromes are Peutz-Jeghers syndrome, where there is involvement of mucosal hyperpigmented lesions on the mouth and lips and so on. Is a family history of that. The juvenile polyposis syndrome, Cowden hematoma, serrated polyposis syndrome. Serrated lesions are flat lesions that have a sawtooth kind of like appearance. And when in this polyposis, there are multiple of this. And then a lot of gene panel testing can detect many of these colorectal cancer syndromes. Risk factors for colorectal cancer, basically they are non-modifiable and modifiable. Age is one, gender, hereditary, personal history of other disease. The modifiable, that's the area that something can be done about. Preventive measures go a long way to reduce occurrence of colorectal cancer. Diet, for one, high saturated fat intake, low fiber diet, and consumption of red and processed meat have been implicated in the processes that lead to colorectal cancer. Lifestyle, social habits like smoking, alcohol consumption, low level of physical activity, obesity, and so on. Diabetes have been implicated, and then there are precancerous conditions like adenoma, like I've said. It's not all adenomas that progress to cancer, but it's important to know that adenomas are pre-malignant lesions. Familial adenomatous polyposis I've mentioned. Inflammatory bowel disease, luckily that's not that common in our environment, but things are changing. Epidemiological shift in dietary pattern, Western dietary pattern, better diagnosis, and so on. You seem to have a lot more of that. It used to be said that colorectal cancer was uncommon in our environment, mainly due to life expectancy, the age, and then these pre-malignant lesions not being that common, and then also radiotherapy. Colorectal cancer survival. You can see that in localized diseases, there's a 5-year survival of 91%, and locally advanced 73%, and then it drops drastically for distant metastasis to 12%. That goes a long way to say that early detection and prevention are key to management of this. Before we progress, I like to differentiate between screening, diagnosis, and surveillance. Like we know, colorectal cancer, they present, besides being asymptomatic sometimes, the typical presentation are blood in stool. That's the one that makes people seek help. Nobody likes the sight of blood in their stool. Change in bowel habit, iron deficiency, anemia, abdominal pain, abdominal mass in advanced conditions, and the likes. These are symptomatic patients, and diagnosis is made. Screening is in people with no signs or symptoms of colorectal cancer, and then surveillance are for those that a disease pathology has been detected or treated, and they are being followed up for to monitor the condition. To emphasize, what are the criteria for screening? They are threefold: the disease, the test, and the program. For the disease, the pathology has to have an early stage that is recognizable, and then the early stage treatment should be more effective than at a later stage. And then it should sufficiently be common to warrant screening. Like we've said, there's a rising incidence in our environment now, so that meets that criteria. Now, about the tests, they have to be sensitive and specific. Sensitive, they should be able to detect what they intend to detect. Specific, they should be able not to detect it if it is not there, and then acceptable to the screen population, safe and inexpensive. About the program, it should be adequate. There should be adequate diagnostic facilities for those with positive test results. So this is one of the things that influences the modalities among different climes. And then the program should have high quality treatment or screen detected diseases. Screening repeated at intervals if the disease is of insidious onset. And then lastly, the benefit must outweigh physical and psychological harm, just like every aspect of medical treatment. You have to weigh that critical balance. Risk stratification for patients in screening, broadly, they're divided into average risk and high risk. What are average risk? I mean, these are individuals that are within the screening age, 45 to 75. I say 45 here. Like I mentioned earlier about the median age for cancer in Nigeria, is believed that these adenomas take 10 to 15 years to progress to colorectal cancer. So the idea is to catch them at an earlier age. So if they occur more at 60, so 10 years below that 50 should be a good age to start screening. That was how it was before, but with an increasing incidence of young onset colorectal cancer. Many Western guidelines have dropped that bar to 45. So the age range between 45 to 75, then individuals, no personal history of adenoma or sessile-serrated lesions. Sessile-serrated lesions are also pre-malignant. Inflammatory bowel disease, high-risk genetic syndrome, cystic fibrosis, and childhood cancer. Then these individuals have to have negative family history of advanced adenoma. Advanced adenomas are adenomas that are more than 10 millimeter with villous architecture and dysplastic features that are unfavorable histology that portend malignant transformation. And then negative family history of colorectal cancer. For the high risk, these are those with personal history of adenoma or sessile-serrated lesions, colorectal cancer, inflammatory bowel disease, childhood cancer, youth, young adults, cancers, high-risk genetic syndrome, like I tried to allude to in the previous slides, cystic fibrosis, positive history of family history of advanced adenoma or colorectal cancer. These are all drawn from the National Comprehensive Cancer Network guideline. What are the screening modalities? They are fourfold. They are fecal tests, blood-based tests, imaging tests, and endoscopy tests. The fecal occult blood test is where you all started from before. In this, the hemoglobin, it's an indirect way. It assesses for blood in stool. It's an indirect way of screening for cancer in the sense that advanced adenomas, which are more likely to transform to colorectal cancer, are more likely to bleed. And then hemoglobin has the heme portion and the globin portion. Heme, coincidentally, is also, that's made from porphyrin and so on, is also found in a green vegetable. Myoglobin is also found in red meat. So there is that high chance of false negativity. The sensitivity is not as high. The fecal immunochemical test is more specific because it assesses for human hemoglobin. And then the DNA and RNA can be assessed in stool, The blood-based tests, you have the circulating tumor DNA, and then biomarkers like septin-9 and carcinoembryonic antigen, which are not very specific, but they are all out there. Imaging tests, we have the traditional double contrast barium enema, more recent CT colonography, and even more recent magnetic resonance colonography. In the endoscopy-based evaluations, we have sigmoidoscopy, which is able to assess the last 40 to 60 cm of the GI tract, and the colonoscopy is able to evaluate the entire colon from the anus to the colon, and is even able to assess the terminal aspect of the ileum. But for our discussion, we'll stay with the colon. And then we have a capsule endoscopy, which is a mini pill that the individual swallows, and it captures multiple images of the GI tract as the pill transits and is eventually evacuated. The individual wears a belt to monitor the progress and when it's out, and the video of it all is reviewed by the endoscopist to flag any lesion. There are two screening models. There's a two-step model where first the individual could do a fecal test or blood-based test or imaging or even sigmoidoscopy. And where there's a positive test in any of all of that, a colonoscopy is then requested. And then there's a one-step colonoscopy evaluation, which is the single most effective because, like I said, if there's a negative test in any of the screening modalities, the patient eventually requires a colonoscopy. So where the means and the facilities are there and the expertise are there, a minimally invasive procedure with in good hands has minimal risk. The colonoscopy option is the one-step modality. Screening guidelines, I tried to look at several screening guidelines, the European Society of Gastrointestinal Endoscopy, the American Society of Gastrointestinal Endoscopy, the United States Multi-Society Task Force, and then the NCCN, and locally, the Society of for Gastroenterology and Hepatology in Nigeria. What is the recommended age to begin screening? As I have mentioned earlier, the reason why in US it was dropped from 50 to 45. In Europe is still basically 50 years. The British Society of Gastroenterology guideline also has 50 years, but going by the 10 to 15 year progression and the median age of 53 years for colorectal cancer patients in Nigeria, 40 years is a wiser choice, and that was recommended by Society of Gastroenterology and Hepatology in Nigeria. 45 to 75. Beyond 75 is an individualized screening decision between the patients, and it's not a hard and fast thing. But definitely beyond 85 years, screening generally is not recommended. What are the intervals? As for the fecal occult blood test is done annually. For the fecal immunochemical test is also done annually. There's stool DNA and the blood DNA every 3 years, and colonoscopy every 10 years. In my practice, I recommend 5 years because we don't have a full grasp of the pattern of colorectal cancer in our environment, and is from careful study and documenting our own literature that we'll be able to arrive at an optimal. Sigmoidoscopy, 5 to 10 years, CT colonography every 5 years. That's for average risk. Then for the high risk, patients with family history of colorectal cancer, a first degree relative with colorectal cancer, is recommended that screening starts at 40 years or at 10 years lower than the index patient the index member of the family who has it, whichever comes first. I try to explain that. Assuming the age of the individual in the family that has colorectal cancer is 43 years, the recommended age for screening of the siblings will not be 40, it will be 33 because the 33 comes first. And then inflammatory bowel disease, the chronic inflammation predisposes to multifocal cancer transformation. And in this, the recommendation is every 1 to 3 years. What I said previously, the guideline was from WEO and then the American Society of Gastrointestinal Endoscopy. This from the European Society of Gastrointestinal Endoscopy, every 1 to 3 years because of the increased risk of colorectal cancer. For patients with mismatch repair deficiency, Lynch syndrome, every 1 to 2 years, starting from 20 to 25 years. These patients have a high lifetime colorectal cancer risk and may consider, we'll get to the treatment options for this. We'll talk about that later. Familial adenomatous polyposis, these individuals, colonoscopy is recommended every 10 to 12 years. It's important to note that a diagnosis of colorectal cancer, of familial adenomatous polyposis, invariably means that in that individual's lifetime, the person will come down with colorectal cancer from having cancer, hereditary cancer-related disorder. So early colectomy may be indicated if polyps become numerous and high risk. The stool test, I would talk more about this, which is more available, more about the fecal or cord blood test, which is most available despite the limitations. And to overcome the limitations, it's advised that the stool specimen is taken on 3 consecutive days. And in these individuals, there should be no abnormal bleeding condition like hemorrhoids or a lady having her menstruation. And then there should be a prescribed diet. By that, 3 to 5 days before that, the individual should avoid red meat and high peroxidase fruits and vegetables. Oxidants and medications, oxidants like vitamin C and aspirin, which can cause GI bleed, should also be avoided. Aspirin 3 to 7 days. Fecal immunochemical test, a single specimen is required. Optimal thresholds are decided, like in the UK, the threshold is 80 micrograms of hemoglobin per gram. In the US is 20. I think a study done in Nigeria used a value lower than that and came up with the observation that it's probable that the high infections and infestations in our environment were a factor leading to the outcome. And for the DNA test, you have single specimen for any of them, DNA or RNA. It's important to highlight that any abnormal test from any of this requires colonoscopy within 9 months. So about colonoscopy, I'll dwell a bit on it because that seems to be the final arbiter. There are quality metrics that are important. These include the bowel preparation, the cecal intubation rate, polyp detection rate, adenoma detection rate. There are others, the withdrawal rate, sessile serrated lesion detection rate, and so on. But I will dwell a bit on this. On bowel preparation, this is one of the major determinants of the outcome of colonoscopy studies. The aim is to have an adequate bowel preparation. An adequate bowel preparation means that the bowel is cleared well enough that lesions less than 5 millimeter can be detected. So when there is inadequate bowel preparation in average risk patients, they should be offered acceptable alternatives. There are known risk factors that have been identified that there are predictive scoring systems that the endoscopists can use, age and constipation, diabetes, obesity, inpatient status. It is a whole list, and I wouldn't go so much into it. But I want to emphasize that in the setting of a previous inadequate bowel preparation, an intensified regimen should be offered to the patient, and this should include at least one of this: an intensification of communication of regimen instructions. A study which I conducted showed that that's from the variables that were studied, the singular independent risk factor for inadequate bowel preparation was found to be the level of education of the patient, because literacy level, the patient is not able to comprehend fully the instructions for compliance. And then restricting intake of vegetables and legumes for 2 to 3 days before colonoscopy, which are high fiber. Another study I did in the European guideline, the ESG guideline, they recommend a 1-day dietary restriction. That's for preparation of bowel is twofold. You have dietary restriction and the use of laxative prep agents, which can be isoosmotic, hyperosmotic, or a combination of the two, and then adjuncts. So for the European guideline, a 1-day dietary restriction was recommended. But our recommendation was that in a high fiber diet population, that a minimum of 2-day restriction is required, of dietary restriction is required for colonoscopy. Clear liquids on the day before the colonoscopy, add pro-motility agents, treatment of underlying constipation. If it's medication induced, there's things like a temporary cessation of anticholinergics, opioids, and other constipating medications, use of high-volume bowel preparation regimens. These are strong recommendations by the U.S. Multi-Society Task Force. For high-risk patients, ab initio, they should be treated as if they are potentially inadequate, and the intensified regimen should be used, because there is a narrow margin of error in the sense that missed lesions in these individuals are more likely to lead to interval cancer. Cecal intubation rate. This is the ability. This is the rate in a cohort of the percentage, the proportion of cases where the endoscopist is able to navigate from the anus and gets to the cecum. And this study showed normally you have the tinea that converge at the cecum. That's the guide to the appendiceal orifice, and you have a blind sac that you are the cecum. But this study conducted highlighted that that the triradiate fold, as the Mercedes-Benz sign, was seen in less than 30% of the patients. So that shouldn't be the all and all. In fact, the best thing is to intubate the ileocecal valve into the terminal ileum, because however, once you are in the terminal ileum and you are seeing the villi, definitely you must have navigated through the cecum to get into the terminal ileum. So there's no point checking for slit of appendix. In some cases, the person might have had an appendectomy and there's no slit, and you don't have this triradiate fold. And The fecal intubation rate for screening is advised to be at least 95%. Adenoma detection rate, this is the proportion of a cohort that an adenoma was detected. So if you had 5 adenomas in one individual, that's 5 polyps, that's polyps per case, that's a different thing. That individual is counted as one case of adenoma in that cohort. So the American College of Gastroenterology and there's an interesting paper from there that's an adenoma detection rate of less than 20 indicates a poor quality exam. And I also mentioned the other things like the withdrawal time is during the endoscopy. There are 2 steps to the endoscopy process. You have the intubation step when you're trying to get to the cecum and the withdrawal stage. Inspection of the mucosa is advised during the withdrawal stage and is advised to slow down and have that withdrawal a minimum of 6 to 8 minutes so that careful inspection behind the folds and all of that are done. And then sessile serrated lesion detection. Well, in my practice, I rarely see that. So I don't definitely, we're not talking about meeting their own yardstick of, I think, was it 15% per study? So that's one thing that our local data would help. And I encourage all those who are doing colonoscopy that when they are publishing any colonoscopy reported paper, that these metrics must be captured in it, no matter what, that it should be captured in the study somewhere so that those who are doing research, when they come to that study, they will be able to extract that aspect and give us something more collective, So colorectal polyps is, I will dwell a bit more on it because once they are identified, they are localized and characterized. Now, in the characterization, the size, the morphology, the margins, and there are a lot of factors. About the size, they are grouped into diminutive polyps, small and intermediate and large. Diminutive are those that are less than 5 millimeter. Small polyps are 6 to 9 millimeter. Intermediate, 10 to 19 millimeter. Large is more than 20 millimeter. Some say more than 3 cm. Now, I'm saying 5 millimeter, 6 millimeter. You ask, how do you know this millimeter at endoscopy? Well, the open jaw of the standard biopsy forceps is 7 millimeter. So if you open the jaw and advance it to the lesion and it envelops the lesion, then surely that lesion is less than 7 millimeter. So that's it. So another way of, there's another critical way of assessing polyps is the use of the Paris classification. Paris classification broadly classifies polyps into polypoid and non-polypoid. And it standardizes, it ascribes numbers, and it standardizes the findings for research purposes. So when you are documenting something and you ascribe a particular figure to it, just like in staging, and you say stage 1, stage 2, and all of that, 2A and all of that, when a study is done, it can be quite objective. So you have the polypoid and the non-polypoid. In the polypoid, you have the pedunculated, where there's a stalk and a head or a cap, and then the sessile, that's the subpedunculated and the sessile. The sessile lesions are lesions that are above the surface and are not more than 3 millimeter above the surface. Here you go again with 3 millimeter. You ask, how do you know 3 millimeter? Well, the biopsy forceps, when it's closed, the width of the closed end is about 3 millimeters. So that's the quick guide. So you have 0, 1P, pedunculated, 1SP, pedunculated, and then 1S, and then you have the other category of flat or depressed lesion, and then the third category is excavated lesion. So this kind of categorizes them, and then it's known that the depressed and especially the excavated lesions have a higher risk of submucosal invasion. All of this help the endoscopist to decide the choice of from his armamentarium, the choice method to remove this polyp. Optical biopsy, yet in the characterization, you have image enhanced endoscopy. With advances in optics and technology, the endoscopy systems now come with functions that alter the wavelength of light or something that helps the endoscopist to be better able to make out these lesions, to predict whether they are benign or whether they are adenomatous or whether they are malignant. For the narrowband imaging classification, it has three components: the color, the vessel, and the surface pattern is up there. The Japanese criteria, it's just a modification of the previous I showed, and it just added a 2A and 2B rather than the type 1, type 2, type 3 of the previous, and with the same aim to predict adenoma or submucosal invasive cancer that require a different mode of treatment. Another way to characterize is a kudos pit pattern. Now, traditionally, a dye like indigo carmine is injected, and this enters the crevices and applies. So from the pit pattern of the lesion, you're able to predict and with magnification, you're able to predict the nature of these lesions, and the types are there. Histologic classifications, you have the adenomas. Majority of adenomas are tubular. It's important to note not all adenomas transform to malignancy. So you have the tubular, the tubulovillous, and the villous. The presence of the villous pathology has a higher risk of malignant transformation, and that plays a role in the surveillance interval. Serrated polyps, I've said, is pre-malignant, is more seen, sometimes more in the right colon. Then inflammatory polyps. In my practice, these form the majority of polyps that are seen, maybe because the infestations, unlike the West, where plastic polyps are the most predominant. Hematomatous polyps, like the Peutz-Jeghers and so on, can have that. And then malignant polyps. With the malignant polyps, you have the Harcourt classification, which characterizes pedunculated and the sessile polyps into levels where you have the lesions at the submucosal lesion level, at the mucosal level, at the stalk level, at the head of the tumor. The important thing is that when the resection is done in such lesions, that the resection margin is free of the tumor, which, unlike the flat ones, which have a higher tendency to migrate into the submucosa, the Kikuchi classification subdivides the submucosa into thirds. So you have the SM1, SM2, and SM3. And it's important to be able to assess clearly using image-enhanced endoscopy, Paris classification, and even sometimes an endoscopic ultrasonography, before intervening endoscopically, and where the lesions are beyond the scope of endoscopic intervention, they are referred for surgery. what are the resection options? You know, there are a whole lot. There are a whole lot. Basically, the use of a snare to ensnare the lesion and resect the. You have the traditionally where it's done with heat, electrocoagulation, and it's also seen that without electrocoagulation, the electrocoagulation, you have that thermal heat that, like in the right colon where the wall is thinner, if you don't apply the right setting or you cook it too long, you run the risk of perforation, okay, involving the muscularis, the muscularis propria. So the talk of cold, generally polyps, diminutive polyps can be safely resected with ensnaring. Just biopsying, using a forceps biopsy is generally not advocated because the risk of, it is a high risk of recurrence. There's incomplete resection is pretty high. So snare polypectomy, 5 millimeter, quite safe, but studies, the European guideline recommends even up to 9 millimeter piecemeal resection, you know, just for the sake of less thermal injury. But traditionally, is the hot snare. Now, looking at the layers of the bowel colon in the image there, you can see for flat lesions, it might be difficult to ensnare it. So injecting some fluid into the submucosa strips the mucosa of the muscularis mucosa such that a snare can be easily applied, and that's endoscopic mucosal resection. Once again, this can be done with electrocoagulation or it can be done cold, paying attention to the sites. And then sometimes when this is, the injection is done and the lifting is not complete, it could mean that there is fibrosis. That's why it's not good, it's not advisable. You see lesions and you just there's random biopsies. It's much safer when you see a complex lesion, to complex polyp, to refer to a center where they are better skilled at it. So when there's a non-lifting sign, it could suggest fibrosis, it could suggest a submucosal invasion. In these conditions where there is need for an en bloc resection, a lesion that is 3 cm can be resected piecemeal by endoscopic mucosal resection. But the pathologist wouldn't be able to assist you with information as regards your resection margin and the completeness of what you have done, which is one of the primary goals of resection, which is to remove the lesion completely and R0, avoid recurrence and minimal complication. So in endoscopic submucosal dissection, with a knife, endoscopy device pass through it, is a knife activated, the lesion is dissected out. And then the advanced endoscopic resection innovation, like a plastic cap, can be applied to the tip and has better suction on the applied over the lesion, has better suction to lift it up before the injection, and all trying to strip it. That's trying to get a comfortable margin to apply your heat that it doesn't get to the muscle layer. Ligation assisted EMR, that's a band, just as you do for a hemorrhoid or varices. A band is deployed that entraps the lesion, and then injection is done, further lifts it up, and then the snare is applied lower down, and safely all of the lesion is brought out. Underwater, the lumen is infused with water. The mucosa kind of like drips away from the inner layers, and the endoscopist is able to ensnare it. Full thickness for deeper lesions that get up to the muscularis mucosa but not serosa, they can be dissected out, and then the muscle layer, all the layers are brought together with an over-the-clip device or some device, the other powered endoscopic resection, So there's a whole lot to colorectal polyps that you see that is something that beginners shouldn't just do things and upstage conditions. There's the algorithms for this superficial mucosal lesion. Are they non-pedunculated? Are they pedunculated? If it's pedunculated, I mean, is a stalk very thick or is it slim? Once you can ensnare it, you can use heat. In some cases, you can inject adrenaline to kind of like vasoconstrict the vessel, reduce bleeding, and all of that. So it's more straightforward, with the pedunculated. The non-pedunculated, those are the ones that, that's based on certain criteria. You can do a cold snare, you can do an EMR and ESD, and then those that you have to upstage to surgery. Malignant polyps, once again, are they pedunculated? Are they non-pedunculated? Is important. Can you do an en-bloc resection, which is ideal? You do an en-bloc resection, pin it to a board, and the pathologist is able to review, gives you a clear feedback on the margins and all of that. Then you now talk about surveillance. So after all of that, post-polypectomy, surveillance, normal colonoscopy every 10 years in my practice, in my environment. I do every 5 years, like I said, to get a better understanding of colorectal cancer in our environment. I have our own data, 1 to 2 adenoma, 7 to 10 years, 3 to 5 years, and then adenomas with high dysplasia 6 months, and there are those that you send for outrightly for when you're not sure of the margins and all of that. That's you recommend the individuals to have surgery. And 10 adenomas 1 year, large polyps removed piecemeal 3 to 6 months. That's the one I was talking about. So in conclusion, the rising burden of colorectal cancer in sub-Saharan Africa and the need for there's a rising burden and there's a need for a national colorectal cancer screening program. A careful discussion of screening modalities is required for patient consent. Sometimes the patient can decline all this investigation, even colonoscopy, and such people, capsular endoscopy is recommended. But colonoscopy is the single most effective screening modality. Refer complex polyps to specialized centers. Thank you for listening. Here are some endoscopic books and available. Thank you so much.
Thank you, Professor Ray-Offor, for this very erudite, extensive, and broad discussion. Without further ado, I'd like to hand over to our international rapporteur, Mr. Emmanuel Eguare, to continue the rest of the Q&A session. Thank you.
Thank you so much, Professor Ray-Offor. And that was an excellent and very comprehensive review of the procedures and the patterns of colorectal cancer. I just wanted to find out, again, with the title Screening Guidelines for Colorectal Cancer, particularly as it pertains to Nigeria. I know fortuitously there was a paper that was circulated this afternoon about the national capacity for pathology and cancer registry readiness, which kind of alludes to some of this. I don't know what your view is when we're talking about the guidelines and the screening guidelines, what we should be aiming for in Nigeria, considering the resource limitations and all in Nigeria currently.
Okay, thank you very much. Staying strictly with this slide, if we are to have a program, there is an important need for adequate diagnostic facilities. So how many endoscopy centers are available in Nigeria? I've seen a paper recently, whether it is sufficient for a population of 200 people. So you will agree with me that there is need for training first before one can recommend a population-based one-step colonoscopy model. The European model, where you do fecal immunochemical tests first for the entire population, is doable if we can upstage. But what we have currently is fecal occult blood tests, which have kind of dwelt on how to improve the sensitivity of it. And that's if we're talking about a national policy. So there are enough labs to handle laboratory tests, but there will be fewer cases that will be negative, that will be positive, that require the endoscopy, which the centers available can now handle. High quality treatment, screen detected, that's what I mean. There is need for training, building the capacity. Colonoscopy is the final arbiter. In fact, that's my emphasis and discussion. Yeah. Colonoscopy is the final arbiter, and there's a need to build, however you arrive at that final stage, be it fecal immunochemical, if DNA, or if I don't know how feasible that will be in terms of cost and all of that. But however, generally, is the stool-based test for population. But my recommendation, or what I have tried to advocate on a local level with companies and retainerships, are select population. That's how would I? It's not entire population. That's where cost is not a criteria. I give you an instance, that's the oil companies and so on and all of that. They can plan on a one-step colonoscopy model in such smaller niches that can, and the important thing, why I push that line still, is that is where we'll gather our data for these pre-malignant conditions and colorectal cancer itself. So that's it with it. And if you go to the last, benefit must not outweigh physical harm. Still comes down to training. Many studies, I've tried to do many research, and people don't document the adenoma detection rate and cecal intubation rate and all of that. And when they are, and there are few studies. So we need to look at the environment and up our game to meet the international standards. So in a nutshell, it still comes down to starting with what we can do and raising the standard to population-based fecal immunochemical tests while building capacity for colonoscopy in regions where those are readily available, and advocate that the health insurance, the national insurance system would step in to cover all of that and price it appropriately, not with the cost of equipment and all of that now.
Great, thank you very much. Yeah, I just with screening, I know one of those things, the quality indicators for screening. If you want to embark on screening, you should be ready to, follow it up to the definitive conclusion. So if you do the fit test on people and they are positive, what do you do with that group of people? And looking at Nigeria and the diverse population, It looks to me like people who have the privilege of the national insurance or the company insurance, it would be a very small subset of the population. And my concern would be if that would be a representative group, because these are people of a particular socio-economic strata, and that will not give you a representative sample. However, I think for us to be able to see those who are raising their hands, I can see Dr. Morodion has a hand raised here. But if we can, thank you very much, Professor Ray-Offor. If we can just put stop the sharing so that we can see everybody. That gives us a clear visibility of people who are raising their hands. And then, but Professor Offor, please stand by to answer the questions. Dr. Irowa Omorodion, yes, you can speak now. You are still muted. Okay.
Yeah. Good evening, everyone. Thank you, Dr. Ray-Offor, for the excellent presentation. I know that we have a lot of challenge when it comes to the issue of screening. Well, I think one of the things that I think society should be doing is to set the standard for what screening is. As we speak now, we may not have even the highest at a particular point. We should be able to do some form of mapping to help us to start off on mapping to see where the services are available and let our people know this is what you must do. Sometimes we may say, oh, we have not gotten it right here. We must get it. We will not got. But I think one of the things that we must set the guideline. What do we do if somebody comes to my clinic, for instance, and come to the clinic and he comes and asks, oh, how can I do screening? What will I be telling the patient? Some patients come because they are not knowledgeable and ask those questions. So if we set a guideline and we're able to know the next step, where to go and what is the best for our people, we can set it. It doesn't mean that we will get there yet. That is why I think about guidelines, something that can give you a guide on what to do. So if we can set those, even with this, our discussion going forward, it makes it easy. We know we have companies who we want to do screening. Those screening the companies even do, we know what it is now. Most of them is at a particular event and everybody forgets about it until maybe God knows when. So we can set up a standard, do a mapping as a society. Let us map where we have colonoscopy functional. That there is no harm within our domain in our country. Oh, go and do colonoscopy there because you need it. Because now, as we speak, many of the patients that will come for colonoscopy are those who have symptoms already. Maybe they are bleeding or something, they have water boil habit, something or pain. Those are the ones we are seeing most of the time that are coming for colonoscopy. Even our study we done locally, those are the group of patients. Very rarely, some people come from abroad because they have relatives. You go and do screening. You see them coming to meet us. We do, but we feel set a standard and let people know about it. It becomes easy that this is possible. Create the awareness amongst our people. That is the first thing, and tell them what can be done and at what stage you can get it done, and put it in the public domain. It will be for us. Then also do a mapping of where the location we can do colonoscopy or who have the competencies to do colonoscopy. I know all of this will involve training going forward, because if the number of people coming for screening actually start increasing, you will be shocked what will happen to the system. There will be a response to it. I only give an example where in Benin, before we had a plastic surgeon, everybody thought that there were no plastic surgery cases anywhere. When the plastic surgeon came, suddenly they started doing a lot. I said, where are these patients? They've been there. So when we create the niche for them and let people identify this is the minimum we need, we can share some of these small things. If we even draw a guideline now, even from our society, I say this is the minimum you require to do screening within our locale because of the possible resources, and we do a mapping of where colonoscopy can be done within Nigeria. I can tell you for free, people can move. They can do that. So let them know, populate it in our platform. Let people know that you can do screening, look at what it is and what. I know about 2 years ago, 3 years ago, 4 years ago specifically, during the colon cancer week, that was in March 2022. Yes, we did a public awareness just at a local. I can tell you the number of people that came in the following months was staggering. We just did it. Okay, we invited people, invited the management, invited the first society. They came. The number of people that came and started asking questions, and that actually a lot of people had, those screening done going forward. When the UPTH, we can do all of those ones. That, because we know the advantage that we know what it requires. So we must do more for our people. We must do a lot of awareness on our own part. We must put a guideline, no matter how little it will be. Subsequently, we upgrade when the numbers start increasing. Population screening involves a lot, we know, but whatever we have, we can manage what we have and save a lot of people. If we do screening, some people come for screening. For the first time, you notice something that man is actually, you have saved him from having a florid disease. But as we have it now, those centers that have colonoscopy, as we have it, they all come. If you come to Benin, for instance, Benin have a lot of facilities, a thing on ground. A city that have almost 4 MRI in town, you have 3 or 4 centers or 5 centers that can do colonoscopy outside of the hospital. So, man, if we have a guideline, with people within this town can go to those centers and have their colonoscopy done. So, I just think that if we generally put a tab and say this is minimum we can do for colonoscopy and sell it to our people and let it be available in all platforms, we can see people will start following through. As long as we do not have one, people will think that this particular thing we are talking about is not for no importance. So thank you very much.
Thank you very much, Dr. Morijo Iroa. Thank you. But just to say, Professor Ray-Offor, you've broken the record of attendances today. Just a moment ago, there were 95 people in attendance, which I think is our highest number recorded so far. So kudos to you for attracting that very high attendance. I will just look at the chat and see the questions we have there. But okay,
Can I just make?
Yeah,
Sorry, the President. Can I just make a follow-up comment because it's relevant, sir? I'm so sorry about this. It's regarding the question you posed to Professor Ray-Offor and also my brother's comments from Benin. So I think we did share some documents, although it came in quite late, on some of the things that were raised. So there have been studies that have been done to do mapping of colonoscopy services in Nigeria. Also studies to show the number of physicians doing colonoscopies in Nigeria. From that mapping study by Prof. Latishe, there are about 198 centers, facilities on paper that are offering colonoscopy across the country. But your guess as good as mine as the number that are actually in service. And they identified 207 physicians that can do colonoscopy in Nigeria. Again, your guess as good as mine as per those who are actually actively doing this. So that already is being done, and so there's data to support that too. There's also data that needs to capture the pathology readiness too, which has also been shared. And there's also data about the impact of fit tests and what will happen if we deploy fit across the country or we do colonoscopy across the country, which ultimately will overwhelm the system too. So there's already data available for all of this. And there are also guidelines from different bodies, NCCN guidelines for our sub-Saharan continent, the SOGIN guidelines for colorectal cancer. So, and then of course the foreign guidelines. So the issue now is how to marry all of this information and all of these guidelines to have some form of practical position statement from society that we can now use as a template for advocacy and for lobbying and for capacity development. So I think there are already the substrates there together for us to put together a very comprehensive position statement. And there's a guidelines committee already in place, chaired by Professor Bakari, secretary by Professor Shino. I'm sure he's going to make some comments in due course. So I think ultimately the society has to have a position statement on all of this, that we can endorse the guidelines that are available, give a statement on what can be done to help in driving this forward. Those are my comments. Thank you.
Okay, thank you so much. Professor Oshino, you have your hand raised there.
Yeah, good evening, everyone. Can you all hear me, please?
Yes, we can.
Yeah, Professor Emeka has spoken extensively about colon cancer. And one thing that's evident now is colon cancer is on the rise in Nigeria. The incidence has increased over the last 2 decades, and Professor Emeka has pointed out everything about colon cancer and what we should do. Right. But when it comes to screening, there's a problem with screening in Nigeria because of the resources and competencies available in Nigeria. They are quite limited. You'll have to agree. Everybody here has to agree with me because I'm going to create a scenario for you. I don't know whether Professor Emeka will answer that question. If I want to scope 1,000 people in Nigeria, suppose I have an NGO that gives me 150 million, say we should scope 1,000 Nigerians, right? If I were to do it in my facility in Lut, I'm not going to talk about private facility. I'm going to do it in my facility. I'm going to do it in Lagos University Teaching Hospital. It's going to take us about a year and a half to do that because we're going to probably at best we do about 60 per month, right? That means it's going to take us a year and a half to do 1,001 cases of screening colonoscopies. So that tells you the challenges we have in Nigeria. So whenever this discussion comes up about screening, right? Whenever it comes up about screening, what I always emphasize is it's good to talk about screening. People should be aware because when we talk about screening is a form of awareness, right? Because when you talk about screening, you're going to talk about awareness of the disease because screening and awareness, they're almost interchangeable because before you can tell an individual, go and screen for this disease, you must have told him, must have told he or she that, this disease does exist and you need to be screened for it. So screening and awareness, they're almost interchangeable to some extent. So what I will emphasize is as physicians, as stakeholders in the country, you should try and increase the awareness of colorectal cancer in Nigeria. People need to be fully aware there's been a rise because I did a lot of colon cancer cases. Less than 20% are stage 1 disease. Less than 20% are stage 2 disease. I rarely see stage 1 disease. Most of my colonoscopies are diagnostic colonoscopies. So that tells us the challenges we have. I don't think as physicians, we are working hard enough to create awareness. Because when we create awareness, that's when there can be an uptick in the screening. Maybe the resources are not there yet, but when people realize, when there's an uptick in the number of people coming for screening, you'll be surprised. We are quite resilient and resourceful in Nigeria. When somebody suddenly realizes that, I had 20,000 coming for screening last month and I couldn't assist them. I couldn't assist them. I couldn't screen all of them. People will be quite innovative. As Nigerians, we're remarkably resourceful and creative. We do it. So what I will advocate as physicians, we should try and increase opportunistic screening. We should try and increase awareness, feet, and everything. We should do everything. If screening modalities available, if they can afford it, they should do it. But they still have to appreciate that the gold standard is still colonoscopy. They still appreciate the person says, I don't want to do a colonoscopy, I want to do an FIT, I want to do a fecal occult blood. Go and do a fecal occult blood test. Go and do an FIT. Because before you can even tell somebody to go and do an FIT or a fecal occult blood test, you must have told the person about colon cancer. So everything is all about awareness.
Thank you so much, Professor Shinawa. I think I agree with you. Some of the points you raised there is the issue of awareness. And but my view of this is awareness brings an uptake. Uptake will increase the volume. And I think we as a pressure group should be able to use this to our advantage because my experience with any new facility or equipment or procedure is that once the numbers go up, the cost of providing that should come down. And in a country as populous as Nigeria, we should be able to use this to our advantage, particularly with the industry. Once the screening starts, maybe with fit test, and you are beginning to generate the numbers, that is the opportunity for us to go back to the industry, those who provide us with endoscopic facilities, and begin to bargain or negotiate on because you're getting more volume, volume will bring more numbers, numbers should bring down cost. And then that creates opportunity for training and then increase in competencies. This is the way it goes. And I just think we have a good opportunity here now that we're discussing this. And I think this is the best time to really strike. So I'm happy that this conversation is taking place. And I agree that we need to increase the awareness and to be able to offer answers to people who are asking the questions eventually. What do you do if your fit test is positive? That's a question. And if the people don't have the wherewithal to economic resources to progress with the treatment, which is an endoscopic investigation to confirm that, what do you do with that patient? So these are some of the questions, but I just want to look at some of the questions we have on the chat. And Dr. Oladio,
Can I chime in a bit?
pardon?
Can I chime in a bit on
Okay,
the
yes,
last?
yeah, go ahead, yeah.
He talked about having 1,000 colonoscopies. I said that's a good problem because it's when you have a problem that a solution comes. That he'll do it in a year. I don't think that's exactly correct. I was in a center in Roswell Park Cancer Institute. They have 3 suites, and on the average, each suite does 15 or so per day, starting from 7 o'clock. That's endoscopies, that's be it upper, lower, and all of that. So I was challenged by that. And when I came back, it's very doable. You can do 10 colonoscopies in a day with ease with your team if you have it all arranged. You schedule 1 hour interval, and it's not going to be a crowded setting. 1 hour intervals, that's for each procedure, and you have 30 minutes. That's back to back. The set that comes in as the procedure is in. 30 minutes into that procedure, that's the time that was given for the next set to come in. So that's for one endoscopy. So if you have, the summary is that what I experience can readily be replicated here. So the issue is there's a problem. There's a rising incidence, and you are seeing them at advanced stage. If you nip this thing in the bud, it's going to be better. So create the awareness towards people knowing that this can be prevented by attacking it early, and then raising the capacity. It's all going at the same time. You don't say create the awareness, then after all the awareness is created, then you go and start training. And the centers that are available, challenge them to full capacity. And you see them quickly train up other people, and the problem will be solved, but you have to be on the path to resolving it. That's my take.
Yeah, I agree with you also. You talked about Rosa Park Center there, but again, some of the things you have to understand, if they were doing about 15, you have to think of the process. How many scopes do you have to recycle? What is your washing capacity, or sterilizing these my equipment before you use them again. So all these things are the things that really limit you. So I can understand where if Professor Shinowo says he can only do that number, but what we need to do, what I'm saying is, this is an opportunity for us to really upscale, and we can actually increase. But we just start from where we are now and challenge and raise that awareness, and that would bring the other services. And Professor Ladipo and Nimsi Gladipo, I think I saw you raise your hand there. Yeah, yes, thank you.
Yeah. Sorry. Thank you very much for calling me on. I almost forgot what I was going to ask, but it had to do a lot with the the intention with which we are actually trying to ensure that those markers of completion are actually being achieved. For example, in the setting of the practice of colonoscopy in Nigeria and developing countries. For example, do we have standardized systems for reporting and a validated mechanism by which we can measure trainees' competence to be able to say these are actually qualified to be able to do this procedure? And how do we just depend on logbooks? How do we confirm that they're actually achieving this? And what are we doing to ensure that these things are achieved?
Okay, thank you very much. And I think that raises another question for us to increase or ensure the quality of the reporting system. This is where, again, investment comes in, that if we can incorporate in the process of screening, there has to be an electronic reporting system or a standardized reporting system that everybody subscribes to. So if I'm reporting my endoscopy in Benin, it has to correlate with the reporting in Abuja. So when we are collating our data, there should be homogeneity rather than everybody reporting differently and the key indices are not achieved. But even when it comes to Sika intubation, it's by experience that Sika intubation increases with the use, with your experience. And you can only achieve that by doing more. You cannot achieve 83% Sika intubation rate by doing 2 or 3 in a month. This is something you need to keep doing and reassuring yourself and having evidence, photographic evidence, and all the other parameters to confirm that you're actually achieving that rate. But with every competence, your learning curve has to correlate with how many of this you are doing. So, but I would say even at this stage, the Sika intubation rate should not be our goal, but rather to actually start doing it. And when you start and you are increasing doing it, you just get better at doing it. And the more you do, the better you get at doing it. I see Kenichuku.
Yes, thank you. Thank you, Professor Ray, for this really great presentation. I was just going to add that as we think about screening, we should think about the entire ecosystem that also needs to develop besides the endoscopist to make this be something that's fully sustainable. In my experience, for example, in my practice in Lagos, pathology used to be a big issue because if you start doing a lot of screening colonoscopies, you're going to have polyps and you need to send them to pathologists who have seen enough of them to be able to tell you if it's a tubular adenoma, is it serrated. I had a period where all the polyps that we were sending were coming back as hyperplastic polyps, but these are polyps that are clearly not that. And so there's the training that needs to go on in that segment as well with pathology. I think that this society can do more with also carrying on nursing as well, right? Endoscopy nurses that are specialized in doing just this and then develop that. But the way that an endoscopy unit can get to a point where we're doing 20, 30 cases in a day easily is that everyone is developed and is doing their own part well. And so by the time that I come into the room for the procedure, things are set up and it's a well-oiled machine. But I agree with Professor Ford that we can get to a point where doing volumes and being efficient shouldn't be a problem for us, but we have to be intentional about putting measures in place for it.
Absolutely, I agree with you 100%. Thank you so much. Yeah, Professor Shinobu, before I call you again, there's a question on the chat here that has been languishing here. I want to just read that out I think Professor Ladip already spoke there. I don't know if I should leave the questions for now for want of time, because you asked is I'm curious to learn the basis for which the lower age for screening, that is 40 years, was arrived at for Nigerians. And number 2 question, for screening tests, what are we not, or what are we using fit test for? And And why 3 consecutive samples? Questions to you, Professor Offor.
Okay, let me start with the first. I mentioned that from literature, it takes 10 to 15 years for adenomas to progress to cancer, and that not all adenomas can become cancers. So you need 10 to 15 years lead when you are choosing your cutoff. The study I presented, I chose that because it corroborated my own study or our study from Rivers and Bielsa, where we had the median age of 52 years, and that was 53 years. So you agree with me that that is a lot lower. So 10 to 15 years brings it down to 40. And that's it. Before it used to be said life expectancy was lower and all of that. I haven't looked at the data, but by an anecdote, people are living longer, and yet you have this. Any study that is done in Nigeria would have a significant population of patients that are less than 40 years. So that is the basis for that. Now, I said for fecal occult blood tests, that's the one you do 3 specimens. Fecal immunochemical test is 1 specimen. The idea of 3 is to increase the sensitivity. That's like I said, it's an indirect assessment, checking for blood, and blood will only be there if it's an advanced adenoma that is bleeding or an early stage lesion that is bleeding. So a rigorous attempt at detecting that's the high fidelity fecal occult blood test. And the prescribed diet I mentioned, that's those things in place to reduce the false positivity. I think those were the 2 questions. Is there any other one?
Yeah, I think that answers it. Then you talked about the fit also. I just think fit is a more sensitive test than the FOB test that is being used. And your explanation for why you could have false positives for FOB tests, I think is valid. I mean, in the country where I work now, when they started the screening test, the age was 55. On your 55th birthday, you get the test in the post. That was the birthday card you got from the government. You got it and you perform the test, you package it and send it back in the post. If it's positive, you get an appointment to come in for a colonoscopy. And if it's negative, you get a reassurance, and then that's to be repeated again in 3 to 5 years. So they are different. Currently, that age, because they have screened the 55, they've captured most of the population. They've raised it now. So it's your 60th birthday now. Once you are 60, you get it in the post, But some people who have the resources just go straight for a one-stop endoscopy and don't bother doing that. But like say in Nigeria, we have to start from somewhere, and that calls for us to really apply a concerted effort to get this going. Professor Shino, if I can I know your hand must be tired raising up now. So after you, I can address one of the other questions.
Thank you. Sorry, my internet, I had an issue with an internet. Like I was saying, I did mention that we can't save everyone. I said we can't save everyone. I was quite emphatic about that. Even in developed countries, they lose patients to metastatic colon cancer. Yeah. So the implication of all this is all we need to do in Nigeria, whether you're offering your patient FOBT, FIT, in the process of you offering your patient FOBT, FIT, or a colonoscopy, you're going to be creating awareness, because the patient is going to ask you, why am I doing a fecal occult blood test? Why am I doing an FIT? Right? All this, as physicians, when we start offering them to patients, right? When we start offering them, we're indirectly creating awareness about colon cancer. In the process, you are telling the gentleman or the lady that your FOBT has level of sensitivity and specificity. Of course, you're going to talk to the gentleman in a layman terms. Come, just because it's negative doesn't mean it's negative, doesn't mean that you have a disease, doesn't mean you don't have a disease. Nothing is bulletproof. The only thing that is bulletproof in this situation is the colonoscopy. So we are indirectly increasing awareness about colon cancer. So my take on all this is, as physicians, as a society, we should increase awareness about colon cancer in any way we can do it. Whether you're offering your patient FOBT, whether you're offering your patient FIT, when you're offering your patient FIT, we're indirectly telling them that, come, we have a disease that is increasing. Nigeria, another reason why we need to do a lot about colon cancer is it's been shown in literature that the incidence of colon cancer in sub-Saharan Africa is going to constantly increase till like 2040. By 2040, Nigeria will probably be the third most populous country in the world. So you can imagine the burden of colon cancer we're going to have. We're going to have about 1/3 of our patients are less than 40. So the rest are about 40. So the ones we can save, let's try and save them and pick them early. Thank you, everyone. And thank you for all the contributions everybody has made. Thank you, Emeka.
Thank you so much. But before I continue, I know we have more questions. Mr. President, how are we doing with time?
We have actually we are past time because we're meant to end at 9:30, but we could still have allowance for about 10 minutes or so.
Okay, yeah, because this is so topical, and I think people who have asked this question, we should give them the benefit. And Professor Offor, thank you so much, because you've really put in a lot to stimulate and stimulate this conversation. Dr. Offor asked a question. To what extent is adenoma detection rate more of endoscopy's competence versus being influenced by the adenoma prevention prevalence rate of the population?
I can go with the question?
You can go ahead.
Okay. It's a mixture of both. But to a large extent, the endoscopy-related factor is a lot more significant. It's like scripture: when you seek, you find.
Yeah.
If you don't have a good bowel prep and you are on the lookout for these things, and then you have system that has this optical biopsy thing, as you are very unlikely to pick them up. Like, I think I have the only pure screening colonoscopy study in Nigeria, to the best of my knowledge. I made a campaign to a company, a multinational, and they sent individuals who were up to 50 years in their company. And from that study, with the awareness of and the training received abroad, I was getting adenoma detection rates higher than all the reports that we were able to put together in a systematic review we did of all colonoscopies done in Nigeria. So the issue is when you look, you find. So that's one. And then the quality of bowel prep is the other thing. The quality of bowel prep is so critical.
And maybe to add to that, the quality of your equipment also, because if you have scopes with high resolution, it gives you more. And even currently now, the scopes we use have AI enhanced or enabled detection rates. So as you are scoping, it just puts green boxes around everything that looks like a polyp, and then you can zoom into that and have a look. So it will get to a point that you don't even need to be proficient at detecting it. The computer will detect them for you. All you need to do is pay attention. So things are advancing from that point. So again, but like you said, the more you look, the more you see, and you get used to seeing them from experience. And that's the way it is. But because I think we are running out of our 10 minutes, but I will read Dr. Ayogo's chat. It says, thank you, Professor, for quite detailed. We need an updated data on capacities available, emphasis on increased awareness are well taken. That question, I will leave that for Mr. President so that you can update the data on the system. And Dr. Osondo is asking a question. My question is, what guide the interval for screening? And I think you've answered that in terms of how your age selection, again, that's population based, and that's decided based on the population. But this is where accruing data comes in. With the more, the larger your data, then you can be more confident at determining that age range. And Dr. Osondo asked another question: how do you ascertain negative margins with EMR? Again, this is where our histopathologist come in. I wish we have a histopathologist here on the platform who could do that for us. And then the other two comments is, well done, Professor Ray-Offor, well done, and thank you, Professor Ray-Offor. And I think it has been an excellent presentation. Thank you so much, very erudite, and I think we are going to take so much away from this presentation, and I think it stimulated the conversation. And I just want us, my appeal is that we keep it going, and we can actually put some pressure on industry to provide some of these things, because the more numbers you get, it will be to their benefit. So I think we should be exploring all those areas. Thank you very much, and I'll hand to Professor.
Right time.
Yeah.
To Dr. Sondu, that's the first question was what guides the interval? Now, what I said is that when a polyp is seen, it is carefully assessed. Now, there are things that predict the risk of submucosal invasion. For instance, diminutive polyps are very rarely have any infiltration to the submucosa. But the larger the lesion gets, the flatter the lesion, that's lateral spreading tumor. You have the non-granular and the granular type, and then the depressed type, So carefully characterizing them. And the histology is the most important thing. If there is high-grade dysplasia, the histology predicts the risk of malignant transformation. So you want to see such at a shorter interval. If you do piecemeal resection where you are not sure of your resection margin, that's 6 months, that you do a shorter interval, so that if there is a recurrence, endoscopically, there are methods to also remove that. That's it. There was a second question. Well, I couldn't remember, but I hope that addresses that aspect.
Thank you so much. Yeah, I'm conscious of time. I'm sure we can continue all night, because this is a very interesting conversation, but we are mindful of your time. So I will hand back to Mr. President.
Thank you very much, sir. So I'll be very brief with just 2 or 3 comments. The first thing is that to appreciate everyone for the attendance, for the active engagement, and most especially to our speaker, Professor Ray-Offor, and our international rapporteur, Mr. Emmanuel Eguare, for handling this session so well. Secondly, for the statement that the society will need to make regarding this, like I said earlier on, there's already a guidelines committee that has been doing some preliminary work on this, and that's why I'd shared some documents on our WhatsApp page, which I'll enjoy us to please have a look. And by coincidence, the National Institute of Cancer Research and Training in Nigeria had reached out to us to develop some form of guidelines or some form of statement for them to use in terms of colorectal cancer screening in Nigeria. And we're working with that mandate to an extent. And so hopefully once we have some document to share, we'll put it to the House to have a look, and so that everybody will be aware of it before we submit some form of documentation to NICRAT for their perusal and possible adoption, depending on how things go. And then thirdly, as announcement that will be in due course, but we have our mid-year OGM coming up shortly, most likely in June. The Secretariat will reach out to us regarding the details as it comes on. But once again, I'd like to thank us for our patience and for the time, for our attendance. And I'm sorry that we short over the time, but I think it was worth it. Please enjoy the rest of the week and have a pleasant night rest. Thank you.
Thank you.